Solving back pain. Functional Dynamic EMG to analyze muscle imbalance, a real patient study. Imagine this: 10 days of sudden back pain that shoots down into your thigh. You get an MRI and it shows multiple disc bulges. Naturally, the first thought is, do I need surgery? But not always. Today, I'll walk you through a patient's case and show how we combined careful examination, MRI, and something called EMG, muscle testing, to find the real cause of his pain and design the right treatment plan without rushing into surgery. Treatment of back pain needs to be meticulous, scientific, and step by step. The video is long, but be patient and follow up to the end to understand how scientifically we can avoid surgery. You will understand the latest and advanced functional dynamic EMG and how it helps in treatment. This video is for patients, families, and even physiotherapists who want to understand how to approach back and leg pain scientifically but in a simple way. You'll see step by step what patient told us, how we examined him, what MRI and EMG showed us, why we chose certain exercises, and how we track his recovery. No guesswork, just clear, structured reasoning. Here's his story. About 10 days back, sudden low back pain started, and the pain began radiating to the front and side of his right thigh. He also had some tingling, but no bladder or bowel problems and no big injury. Now, pain in this area usually means nerves from L2 to L4 are involved, but the cause can be different. It could be a disc, narrowing of the nerve opening, hip related issues, or even nerve entrapment. That's why we don't jump to conclusions with just one MRI. First, we always check for red flags like fever, weight loss, or severe weakness. Luckily, he had none. What we did find was difficulty standing from sitting, short walking tolerance, and a tendency to stay bent forward. Since there were no alarming signs, we could safely go ahead with a conservative, non surgical approach. On examination, his posture was slightly bent and back extension was very limited. His hip muscles, especially the flexors, were tight, and the side muscles, abductors, were weak. Sensation in the thigh was reduced, reflexes mostly okay, but a femoral nerve stretch test was positive. Putting these together, the pattern pointed towards irritation of the L3 L4 nerves. Now let's see the MRI. The MRI did show multiple disc bulges from L2 S1, thickened ligaments, and narrowing in some areas. But here's the key: MRIs show many age related changes, and not all of them cause pain. So we needed more clarity on how his muscles were actually working. That's where EMG comes in. What is EMG? Think of EMG as an ECG, but for muscles. Just like ECG tells us if the heart pumps properly, EMG tells us if your back and leg muscles are firing the way they should when you move. It shows us which muscles are too weak or asleep, which muscles are overactive and tight, and how restricted your movement really is. Instead of guessing which exercises might help, EMG gives us a clear roadmap of what to strengthen and what to relax. Let's see patient's EMG pattern. In patient's case, EMG revealed weak stabilizers, like the glutes, quadriceps, and deep back muscles. At the same time, his paraspinals and hip flexors were overworking. No wonder he couldn't stand straight. His support system was switched off, and the wrong muscles were working overtime. Let's see treatment plan. We made a phase-wise plan. Phase 1, weeks 0 to 2. Calm and activate. Relieve spasm with IFT and ultrasound. Gentle nerve glides. Activate the core, glutes, and quads with simple moves like pelvic tilts, glute squeezes, and static quads. Stretch hip flexors. Here the goal was simple: wake up the weak muscles and calm down the overactive ones. Phase 2, weeks 2 to 4. Build support. Strengthen glutes with clamshells, bridges. Train core with dead bugs and marching. Stretch hamstrings and hips. We checked progress using EMG and walking tolerance. Phase 3, weeks 4 to 8. Strength and function. Step ups, sit to stand practice, planks. TheraBand training for hips. Balance exercises like tandem stance. This phase prevents recurrence by giving him real life strength. Why not surgery? You may ask, why not just operate? Because his case was mainly functional imbalance with nerve irritation, not severe compression. Surgery is considered only if there's progressive weakness, foot drop, or bladder/bowel involvement. Since he had none, conservative care was the safest and most effective choice. Progress tracking. At home, patient tracks his pain score, numbness, and walking time. In clinic, we repeat EMG to check if his glutes are firing better and test sit to stand and walking. This way, recovery isn't vague, it's measurable. So today you saw how we connected the story, the exam, MRI, EMG, and then built a structured plan. EMG didn't just tell us that muscles were weak, it told us which ones to strengthen and which to relax. That's how we designed a program tailor-made for patient. If you know someone struggling with leg pain, share this video. And if you'd like a structured evaluation and EMG guided physiotherapy, check the details below.